Well, hello out there in blackdoctors.org land. This is Dr. Melanson, and I'm here every week. But this show we have a special guest that I'm going to be introducing. We have Dr. Calendar, who from MOTEP, who's going to be here as usual, and we will be in our normal roles, but presenting today is going to be one of my partners at George Washington University, Dr. Pablo Serrano. Dr. Serrano, like myself and Dr. Callender, is a transplant surgeon, and we share the responsibilities of doing transplant on the kidney and pancreas transplant recipients. He heads up the pancreas transplant division, the surgery division, and he trained at Georgetown, which is basically just down the street from here. He did his early training in Mexico, where he's a native, but he has been in the United States now for some time. He came to us from the University of North Carolina, where he was also the lead in their pancreas transplant division. So here, like he had done in his prior life, he's headed up our Hispanic clinic. This is very important because although in blackdoctors.org, we're often talking about African Americans, the other group of people in this country who also share a lot of our problems insofar as obesity, diabetes, hypertension, kidney disease, vascular disease, are the Hispanic patients. In in the DMV here in the Washington D.C. area, the largest growing demographic are the Hispanic patients. They come from different parts of the world, but it is the Hispanic or Spanish speaking population. So Dr. Serrano starting the Hispanic clinic here at George Washington has been a big boon to our practice. So he's going to be giving us some of the background as to why a Hispanic clinic is of the utmost importance in an urban area like Washington, D.C. So without further ado, Dr. Serrano.
Thank you, Dr. Melanson. Thank you, Dr. Calendar, for the opportunity. I'm very happy to talk, about my work in the Latino Transplant Clinic. We'll talk a little bit, as Dr. Melanson said, about the sort of the disparities that are a lot of them are shared between the African American community and the Hispanic or Latino community. We see most of our patients that it's one of the things that really interested me about taking this job is all the work that Dr. Melanson, Dr. Johnson, Dr. Gray have done in the African American community in the DMV area, that I could do something similar with the Latino population that obviously I share a bond being Mexican. And I'm very proud of the work I've done. I will talk a little bit about the work I did in North Carolina. Here we had less than a year with the clinic so far, so we still don't have all the data, but we can see that it's successful and that it can work. So if we can get the
slides. So if we could just put up his slides. There we go.
Thank you. So I always like to start all my talks saying that I'm Mexican. I'm very proud to be Mexican. And now that Mexico is getting a little bit of bad rep, let everybody know that Mexico is not just the beautiful beaches, although it does have beautiful beaches. We have the biggest city in all of the Americas, Mexico City, and it's a city with the most amount of museums with any other cities in the world. It has a lot of culture. So what you can see in the top left is the kind of like our opera house, the Museo de Bellas Artes, where there's always a theater and great exhibits done there. Then next to it, it's San Miguel de Allende, that it's a great colonial place to visit. And under it is the pyramids of Teotihuacan, that it's a beautiful place. Nobody really knows who built them. They've been there for centuries. All the cultures that have ruled Mexico have used it as a religious area in Mexico. And the pyramid that you can see on the back, that is the Pyramid of the Sun, is the same size as the pyramids of Egypt, but it's just not as steep. So there's a a lot of beautiful things to see in Mexico. We are very friendly, and it's a great place to visit and to learn from. Next slide, please. So, just like you saw in the introduction, there's no clear way of determining the group, either Latino or Hispanic. Now a lot of people are using Latinx, and it varies. And throughout this talk, we will refer to as Latino. I would use it for referring to all these groups. I would say that obviously it talks about almost everybody, from south of the Rio Grande all the way to the Patagonia Peninsula. There's a lot of difference, right? We, as you can understand, just like it happens with the African Americans, depending of different areas, you can have different disparities. It's the same here, right? We have Latin people from African descent. We have Latin people, for example, in Argentina and Uruguay, that are mostly the same as our Caucasian. And then we have a lot of people in all of areas of mostly what we call Mesoamerica or Mexico and Central America, where most people are more related to the indigenous people that used to live here in America. Next slide. So I think that one of the big questions is why we need a Latin transplant clinic or a Latino transplant clinic in any area of medicine or in the United States. And as you can see from the census, the Latin population is the fastest growing minority in the United States. It's right now it's about 18% of the population. It's calculated to be around 25% of the population by 2050, or even 30% of the population by 2060. From 2010 to 2019, half of the growth of the United States is mostly just Latin population. The other thing is it's also a very young population. Our median age right now is 30 years old. So you can see that it's something that we're going to see a lot of. Obviously, once the second or third generations, you're not going to have issues with the language, but part of what we want to show is that it's not just translating what we do in English, but also trying to make something culturally sensitive. And as I said, almost 80 to 85% of the Latino or Hispanic population in the United States comes from what we call Mesoamerica, that it's Mexico and Central America. Next slide, please. So, and this is, I really enjoyed this movie, Coco, if anybody was able to see it. This is what we normally see with a Latino family, right? We normally have a big family. We're very family oriented. It's something very, very important, something I think we share with a lot of different cultures. And we normally have, a matriarchy or someone that is the leader, that it's normally grandma, la abuelita, that will help us decide. A lot of times, when you deal with patients, and this is something you have to understand, is that you have to see these cultural differences, right? So sometimes you need to, talk to the wife to see what the husband is going to eat, that he's going to take his medications, because she's the one that could put pressure on him. If you want somebody to donate, well, you have to convince, the grandma to make sure that she understands that it's safe, so that she can give, the approval and show that it actually works. And, this is, some people see it as discouraging, but this is actually a benefit, right? Understanding it and knowing the big families is something that we can use in our advantage, especially in transplant. Next slide, please. So to follow up on this, this is also from the census, showing the amount of children per family. And you can see that the Hispanic population, the Latino population, normally has 4 or more children. So we normally have big families, and that is very, very important, especially for us in transplant, to know that we can look for people for living donation. Once you have, you can convince them, then there's a lot of people to donate, that they understand that this is good for them, that this is going to be good for the whole family. We have a lot of options of people to come in and help the patient and get them off dialysis. you can see that this has not changed, even though the percentage of Latinos being born in the United States has decreased. Next slide, please. So another thing is, the Latino as a consumer, right? It's calculated that in 2020, the Latino population consumed about $1.5 trillion. So, that's not something insignificant, right? So we have to understand that they take a big part of the market. There are people that, pay their income taxes. I know that has been controversial lately, but they pay 100% of sale taxes, of course. And they contribute about $15 billion to Social Security, while they only use $1 billion, right? So it's something that they're still contributing every time that they get paid. They pay to their taxes, and they do show a benefit to society. So it's in our best interest that they return to their jobs, that they are able to access all this to help the rest of society. Next slide. So now, talking about risk, the Latino population, kind of what Dr. Melanson said in the introduction, have a higher incidence of end-stage renal disease. It's about 1.5 higher than the rest of the population. They also have a higher incidence of diabetes and obesity, that I'll talk a little bit more about that a little bit later on. And we could also see that they have less possibilities to undergo kidney transplants, specifically if it's a kidney transplant that is preemptive, or somebody that has been prior to going to dialysis. You can also see that the population, the amount of people with end-stage renal disease is increasing all over the world. The people that are going on hemodialysis, the people that are going on peritoneal dialysis, and this is a problem that is just going to keep increasing. And we have to find ways to help patients get treatment, so that this doesn't affect all the providers and consume all the money that we have allocated for this purpose. Next slide, please. So this is also talking about the risk, about the, by race and ethnicity, the percentage of patients that have diabetes in different groups. You can see that in the African American and in the Latino population is higher than in the rest. You can see the risk of having end-stage renal disease with 1 on the white population, 0.8 on the Asian, and for the African American and Latino, it's twice as likely. And obesity, it's also higher in the Latino. African American is a little bit higher, and the white population also has a pretty high obesity rate in the United States. And all this are big risks for end-stage renal disease, right? Having high diabetes is one of the main causes of end-stage renal disease. Obesity and metabolic syndrome will affect you, have hypertension and having complications, having cancer. Also, and a little bit what we have heard in all these different talks is that it increases your chances that your donor also is not going to be a great donor. So it's harder for this population to find somebody to help them, somebody to be able to donate for them and get them off dialysis. Next slide, please. So now going a little bit into the Latino population in the United States, about 70% of the Latinos are foreign-born, 30% are second generation born in the United States, and less than 60% of the Latinos are fluent in English. A good percentage just have moderate English skills. 18% are uninsured, and as we had said, and we're going to repeat throughout the talk, they suffer from a lot of different disparities, from medical to financial to all the things that we have discussed. And the other thing is the healthcare facilities a lot of times lack the resources and the personnel to meet these language needs. A lot of the issues that were discussed lately about all the populations that were brought in when there was a need for them, and that how they the system, when they showed up, were not able to manage their the schools, the hospitals, the clinics, because they could not they did not have the providers to speak in a different language. That is something that we have to deal with ahead of time, and not just to wait for it to become a problem and be an issue. And something that's very important with the Latino population is the surrogate decision maker normally is the person that speaks the best English, right? And a lot of times it's one of their children. So sometimes you might have, a child taking decision for their parents, trying to see without any information or any support how to fix these problems. And that is something that we have to understand when we're talking and helping them have a decision in group, not that one person and the only person that understands what we're talking about is the one that is taking these decisions, right? This is one more of the cultural differences that we have. Next slide. So I wanted to talk briefly about undocumented immigrants, and this is a map that shows where they're more prevalent. As you can imagine, in the south and in the southwest is where you have most of the undocumented immigrants, but they represent about 11 million people. It's about 3% of the population. Of these, 27% are uninsured, and it's estimated about 6,500 of them are dialysis dependent. Although these numbers are not easy to find, and a lot of people think that they're a lot higher, and they can only get access to healthcare in a lot of places only in life-threatening situations. So I wanted to talk a little bit about the how they can get access to healthcare. If you can go to the next slide, please. So and this is something that I've learned from experience of working in different places. There's once in 1972, everybody that was on that had kidney disease was approved by Medicare to be covered to be on dialysis, and they would cover the dialysis treatment. It did not include, obviously, people that were non-citizens. So in that moment, different states have to come up with ideas of how they could deal with this population. Ideally, you want to treat and find out how to take care of these patients. So in some states, they decided that they would not dialyze and they would have to transfer them to other places. So for example, when I was in North Carolina, you would see patients that would be in South Carolina where they would do this, and they would just, see them on the hospital, give them one treatment of urgent dialysis, and then when they were done, they would buy them a bus ticket, and they would ship them to North Carolina where they knew that we would take care of them. So once they would get to North Carolina, we would have to take care of all these patients. There's places where they approved to have access to Medicaid as an emergency Medicaid to be able to take care of patients. And in California, they have this term called PRUCOL that I don't know if you're familiar. I had never heard about it, but it's called permanent residence under color of law. Just basically gives them the chance when they have an emergency to access Medicaid funds to be able to be treated. In some places, for example, what we did in North Carolina, that it's really difficult to show data for, but the centers decided to join together and to all of them allocate 1 or 2 spots of their dialysis to people that did not have as a charity, that did not have insurance. And they would take them, see if they could get transplanted or if they have any other means of getting off dialysis. And but they would not do it through insurance. They would not get any other benefit. In DC, we have the American Kidney Foundation that it's some of these patients will get access to insurance, and they'll be able through that insurance to get dialysis, and will also be able to get other benefits from having insurance, and even to the point of getting transplanted through this. And I also wanted to talk briefly about the Affordable Care Act. Even though the Affordable Care Act does not let non-citizens get insurance, it did take away all the requisites, the issues that you would have prior to being insured, and that led to patients being able to buy insurance off the market. So even though it's not affordable and they're not getting benefit, it did let people that are non-citizens be able to purchase insurance and be able to get medical care in the United States, because that's something that it's important to discuss. There's been a lot of saying that all the undocumented workers, they're just lazy, they don't have any money, they don't want to pay for their insurance, and we've seen that is not true. And if we would let them buy medical insurance, a lot of them would be able to take care of this and work hard to be able to get enough care. Next slide, please. So, going back to that, a lot of the dialysis-dependent undocumented immigrants are normally younger. They have a lower incidence of cardiovascular disease and diabetes, and they have a strong desire to keep working. In North Carolina, it was very impressive from all the patients that were in my Latino clinic. A lot of them would be, getting the third shift on dialysis, and then they will wake up and they would do construction work every day. And that's really tough work. We had to, see where we would put the fistula so that they would be able to still do construction. They would only be able to lift things with one hand, things like that, and they would still show up. Another thing that we will see is that they have a very high show rate for their clinic appointments and their visits. About 60% of them have a potential kidney donor. This varies, obviously, depending on the situation. A lot of times is just a worker that came to do work and his family is in another country. In that case, it's harder for them to find a potential donor, but a lot of them, if they have family here, they do have potential donors. And I wanted to talk briefly, UNOS used to have a cap of a 5% non-citizens in 2015, a maximum of 5% non-citizens in your list, right? So you could not list more than 5%. And they saw that this does not improve benefits from anybody. So they decided in 2021 to change it to less than 10%. And they saw that all the transplants increased for everybody. So it's this metric that they're taking transplant from anybody else. It's not. We have found that it's not true. Right now, actually, they took away this 10% cap, and there is just a suggestion. So if you want to list more than 10%, it's not an issue. And they've seen that some programs have done this and that it hasn't improved the outcome. It hasn't affected the outcomes or affected the other groups that are attending that center. And you can see that non-citizens are only 1% of the recipients of organs, but they produce 3% of the cadaveric donors, right? You understand that people that are immigrants, documented or undocumented, they still are donors, and they still are, give the gift of life to other people. Next slide, please. So I also briefly wanted to talk about, the dialysis. I don't know if you all had read, and there's a lot of articles and stories and podcasts done about the GOT committee and how dialysis started in Seattle. In 1961, they started getting the first dialysis machines, but there weren't enough for everybody. And at that time, having end-stage renal disease was a death sentence. So they made this committee that decided who would have access to dialysis, right? And as you can imagine, most of the people were white men, because they said that they would take care of their families and do better. And in retrospect, there's been a lot written how they could have handled this better. But after that, in 1972 is when I told you that the end-stage renal disease amendment was made and gave everybody that has kidney disease access to Medicare, and then you can get dialysis, you can get treatment, made access to dialysis and transplant, nearly available to everybody, to all citizens, but non-citizens were still not part of it. So the non-citizens, what they have to do is they have to receive emergent hemodialysis. What does that mean? They don't have they cannot go to a center, in a scheduled basis to get dialysis. They need to wait until they have symptoms. They are fluid overload, their potassium is too high, and then they have to go to the ER to get treated. And it's been shown that this is way, way more expensive than just having somebody in a center. In 2007, they wrote a paper that in Houston, Texas, it was about $285,000 a year to do this. And in Denver, Colorado, it was about $400,000 in 2013. When normally it's about between $60,000 and $100,000 to do it on a regular spot. So we would all benefit, the medical providers, the patients, and the people paying for it, because at the end of the day, it's going to be either your insurance or Medicare that's going to pay for this, if they would be able to get insurance and get dialysis like everybody else in a dialysis center. Another thing that I didn't put here, but I also want to discuss, is there's a lot of data that the best way to get treatment for these patients is with peritoneal dialysis that can be done at home, so they don't have to do in-center. But a lot of times they have issues with a place to stock all the fluids and their solutions, and that's a problem. And when the Affordable Care Act, I discussed it, how that opened the possibility to get insurance through the marketplace. Next slide, please. So then going to the living donor kidney transplant. So a lot of them, as we said, have a living donor kidney transplant. So it would be on our best interest to find a way to get these people transplanted. It would increase the life expectancy of the patient. It would let them go back to work and keep paying taxes. It would also increase the potential pool of donors. I don't know, I'm sure Dr. Melanson has talked about it here, about paired exchange. I think one of the first things that he did when he was in Georgetown, and one of his claim to fame was doing all these big chains and paired exchanges where one kidney was sent to the recipient of somebody else when his recipient was not compatible, and then that recipient had another donor that was sent to another recipient, and you would form a chain. So having more donors increases the chances of this happening, right? And it's also less expensive than dialysis. You have a higher pay-in from the surgery, but once the patient's doing well, and especially thinking that this living donor is going to last 10, 15, 20 years, it's a lot of time they're not going to be in dialysis, and they're only going to be paying their medication. And you can see that the percentage of living donors is still decreasing. That can be said in a way that we're doing more cadaveric, what you can see on the slides, we're doing more cadaveric transplants. So all the ethnicities are percentage-wise are doing less living donors, but as you can see, the Latino population is a little bit lower, and especially one of the things that Dr. Melanson always says, the African American population has a very low living donor kidney transplant percentage in general, and that's one of the things that we're very proud to do here in GW, that we're very high on the African American living donor percentage-wise. Next slide, please. So getting back to the Latino and healthcare, as we said, we have the younger Latinos that are being here are the most established older Latinos who tend to have more issues, then tend to have more disparities, and they have a worse healthcare coverage, about 46% only compared to 91% in the rest of the population. As a new immigrant, as you can understand, if any of you would go tomorrow to another country where you don't speak the language, you would have significant barriers to understand how their system works, especially a system as complex as the healthcare system in the United States. And having to do that through a translator, in urgent situation, it's something really, really hard. So it's really tough to find trust in your providers. I think that's something we share with the African American community, where trust in the providers has shown to be really good for adherence to treatment, right? If you want somebody to take their medication to go to the treatment, they have to understand that you're doing it for their health and for their benefit, that they're really going to improve from doing what you're saying. So you need to have that trust, and it's easier if you can find a way to convey that. Next slide, please. So I just wanted to talk briefly about this slide about what happened in COVID, and I think that's a great example of that, right? The Latino community made almost 1/4 of all the COVID-19 deaths during the early parts of the pandemic. And as you can imagine, there were no interpreters going to the hospital, and there was not a lot of ways to talk about to patients. So they would have longer hospital stays, they would have ICU admissions, they would be intubated, and they would have a higher mortality. And then they would not be able to communicate. It was harder to tell them what to do. And it was, I think it was a great example of what we should not do with these patients, finding ways that we can communicate and make them feel safe. So language services, or speaking in your own language, is a great way to find better empathy and better adherence to the patients so that they can have better outcomes. Next slide, please. And not everything with the Latino population is negative, right? There's something called the Latino paradox, that despite having a lower average income and education, Latino patients tend to have outcomes comparable or better than Caucasians in a lot of settings. So there's actually they publish a Latino paradox with infant mortality, a Latino paradox with kidney transplant outcomes, and there's a lot of them. If you search in PubMed, you will find a lot of them. It's only on the first generation, though, of Latino patients that come here. There's a lot of things being said about how they, are more active, tend to be a little bit less obese, have less tobacco consumption, how they're having bigger families, have bigger support, but nobody really knows exactly why. But it's something that we can show as a Latino mortality advantage that can benefit our patients, and we can see in our clinic. Next slide, please. And then, specifically now going to why what we're doing in the clinic, we have to think of what are the barriers to transplantation. Obviously, the first one is the language, right? If you're talking to somebody through an interpreter, through a video that they have to listen, that's not personal, that is a big problem. Latinos, we're very warm. We like to touch people and talk face to face. And so having somebody that we can ask questions is always important, right? Having somebody in person that can talk to, I think, is very important. The cultural difference between the patient and provider, right? There's this trust of the provider of, well, this is just, should we be treating undocumented people? Should we be treating immigrants? Should we give them the same the same treatment as everybody else? Or they're not gonna, they're just poor, they're not gonna show up. All these things are issues that we need to work with. And then there's no community awareness of transplant. And there's a lot of misconceptions about organ donation. A lot of people think that if they are living donors, women might not be able to have children, that men can have impotence, that they're going to take medications afterwards, that they're going to have a shorter lifespan, and all those things we need to clear them in person. Next slide. So what we do in our clinic, as we said, we want to not just do the same thing that we're doing on our English-speaking clinic, but do a culturally sensitive clinic. So I normally am the one that gives education for all our patients when they show up. They have, be able to have a full-time access to somebody that can answer their questions. A lot of times we encourage them to come in with their families. For example, I have 2 patients yesterday, and each of them came with 4 family members, right? So, the fact that you can talk to them, convince them that this is the best thing for the patient, that they're going to live longer, and if one of them can donate, then you can solve the problem right there. You have to understand the difference in our culture, the importance of family in our community. As we say, we have a matriarchy. So if you find that person and convince them that this is safe, they might approve for the niece or the nephew to donate. How important is faith and religion, telling that in Catholicism, that is what most people practice in the Latino community. John Paul II said that transplantation is the biggest gift of life, and there's approval. I think that you can convince them and tell them that this is something safe, and that people are that they agree with it, and help clearing all these myths and misconceptions that transplant is safe and outcomes are pretty good in all population, and that builds a trust in the provider. We've seen, at least when I was in North Carolina, that we have an over 95% show rate for our clinics, that is higher than we have in any other clinic that we've had. Next slide, please. So for the setup, you obviously need to have at least one person that speaks Spanish that can communicate in person with the patients and understand it. Ideally, he can understand the culture well. It's important you do not show videos, that you don't just play a video of something translated by somebody else, because people are not going to focus. And you need somebody that can follow the patient. These are patients that will need a little bit more hand holding. Next slide. So the patients, it might need a little bit more assistance. It might be a little bit overwhelming at the beginning. They will not have great health literacy, but it's something that we need to help clear it up, be a little bit, have more resources that you can give them, talk to them, make sure that you answer all their questions, make sure you explain why the testing, why you're doing it, what are the results, and then go on from there. And sometimes you need to assist them on getting their appointments, something we do here in our clinic too. Next slide. And just make sure that you're having a good communication with the patient. Here, the way that we started, because I could not be on the phone and we did not have another Spanish speaker, we set up a voicemail in Spanish that they could leave voicemails, and then they would follow up with one of our coordinators, that she could hear them and get them translated, and then we can answer the patient. You can talk to them and clear all the doubts that they might have. Next slide, please. So in our team, we do it the same way that we do our regular clinic. We have a transplant coordinator, a social worker, an administrative coordinator, and then very important is the financial coordinator, to make sure that it's clear to the patients, even if they have insurance, what resources they're going to need to go ahead with transplant. I think that, as we've said, there's a lot of support from the family. So sometimes if you're clear what it's needed for the patient, they can come up with whatever's needed to help their family member and get them transplanted. And then myself, that I try to talk to the patient and answer all their questions and make sure that everything's clear. Next slide. So these are my results from when we were in North Carolina. You can see that our referrals steadily increased. The amount of patients listed also increased. The number of kidney transplants that we did that were from Latino patients kept increasing every year, and the number of living donors steadily also went up. Obviously we had issues in 2020 with COVID that also changed the amount of patients that we had, but you can see that it's something that it does show that these are patients that were not being seen. A lot of them have been on dialysis a long time, and nobody was able to take care of them. And just the fact that we had the clinic and were able to say how was how we got them in the door. Next slide. So you can see that our referral time decreased by half. The time to wait list decreased by 60% from our patients, just from being able to get them from one point to another. As I said, we had an over 95% show rate, and the numbers of transplants increased. I think that changed a little bit, but yeah, we did increase our number of transplants throughout those years that I was there. Next slide. So the conclusion is that the Latino population is younger and healthy, or they can be. We also have an older population that is having more issues with the lack of English. We have to understand that having somebody that can speak in Spanish can really benefit this population. Most of our patients are rural that come here to do hard work, and you just have to be a little more patient. And the Latino population are doing significant contributions to the local and country economy. There are patients that are hardworking and employed, and the healthcare system should have enough resources to be able to take care of this population. Next slide. I think this is my last slide. So we still don't have a lot of data. As I said, some places they just give a lot of charity help, and that's things that we sometimes cannot evaluate. So it's very important to try to get data to show that this is something that will benefit, not only benefit, but that it can be a business. We can see that the Latino population in the talking more about transplant have a higher incidence of end-stage renal disease, that we can do living donations on them, and that the living donation are going to be are something that are going to improve their quality of life and are going to be successful, and that there's room to have a culturally sensitive clinic to improve transplant access to this community. Thank you. I think that's my last slide.
Great talk, Dr. Serrano. I see Dr. Curry is now here, so I don't know if he can, if he's able to speak. But can you hear us, Dr. Curry? Can you speak?
Yeah, I can hear you now. And sorry for late getting on. It technology is what it is. But for the portion of the talk that I was able to hear, outstanding talk. And I would just like to. I think we ought to just dive in and look at a few more. Perhaps Dr. Melancon, Dr. Callender will start the questioning, and as I formulate the questions that I wrote down, we'd like to really ask some serious questions, I think, of Dr. Serrano.
Yeah, I'll start because I work with Dr. Serrano, so
Yep.
I've seen the magic up close and personal, and I tell you, the communication with our Hispanic patients is just so much better since he has come, and I would not have predicted that because we had translators before Dr. Serrano, but having a member of the medical team, one of the actual doctors and surgeons, has just made this so very much better. But I do have some questions, and Pablo, I'm wondering, do you see? We talk a lot about ethnicity on this webcast, and I wonder and I know it's a little bit more controversial in the Hispanic culture, but is there a demarcation between outcomes and access and all these things between Afro-Latinos and other Latinos? I'm just wondering if you see any sort of demarcation based on, I guess you would say, race.
Mm-hmm.
Do you have an answer?
Yeah, I think that most of it it's related in people that have more indigenous ancestry and people that do not. That's normally what we see. At least in Mexico, we do have people that are Afro-Caribbean descendants, but it's not a big population, so we don't have as much data. But we did find that people that have are more indigenous tend to have the same disparities, right? That it's from racial disparities to access to healthcare, the same way that it happens in a lot of different countries. But we do see it, yes.
Okay, thank you. And then one more thing. I know that we have other questions, but one of the things we really harp on here is trying to get the African American community, particularly the urban community, to do more cooking at home. So cooking rather than fast food. And I know in the Hispanic population, you guys do a much better job of that. And you also do a better job, I think, of having family support. Yet a lot, even with the I think what I would hope to be a better diet. So if you're cooking at home, it tends to be healthier and better family support. A lot of the same issues, obesity, ESRD, heart disease, vascular disease, you guys see. What's your take on that? Why do you think those problems persist, even though you guys are already doing, or at least doing a better job than what the urban African American communities here?
Yeah, I think that that's a great point. And I think that there's multiple different things. One is that a lot of the people that in our community come here and do really hard work. And at the end of the day, they end up having fast food too. And you can see a very high impact, when they worked all day, they just go and buy whatever's cheaper. And you can see that people that have been here for just a couple of years, they have gained a lot of weight and they start to have all those issues. But in some places where you still have, this family, they after they do a little bit better and they're able to, start their home and have family, for some reason, and that's something I never understood why, we do not have the Mexican products here like the other communities have. Like you would find, a Caribbean supermarket that brings things, or an Indian market that brings, food or spices from India. We do not have like the things that we normally eat in Mexico. We don't eat sweet corn. We eat corn that is not sweet, and it's impossible to find in the United States, or I'd never find it even though I go to the markets. The tortillas here have sugar on them when in Mexico they don't. The cheese that we use is completely different than the ones that you use here. So I think that also have to do, the market of the food that we take, even though we consume more vegetables and more things, it's still the same as the basic American diet. And that, I think that's why you can still see the issues. As you said, one of the best things is to cook at home, but also try to cook things that are healthy, right? You try to eat more vegetables, eat more fruit, eat less processed things, and that's going to help you. And those things in the United States, it's so expensive to cook, right? And you can't understand when somebody can buy a full meal for $5, or cook something healthy for 20. You would understand that they cannot do it every day. Yes. So I think they also have that issue.
Mm-hmm. Yeah, as you were speaking, Alexander said you seem to have forgotten that there is Taco Bell in this country. So I mean, I don't know why he brought that up. But Dr. Callender,
I've never been there, thankfully.
Dr. Callender, I'm sure you must have a question.
Yeah, this has been a fabulous presentation. I've had a lot of opportunity to look at the work that was done in Northwestern, which kind of demonstrates that you need to have an investment such as you have that makes a difference. Since the Latino population is the number one minority population, it's important to recognize that this problem with the undocumented immigrants is something that reveals a kind of a horrible situation in which the undocumented immigrants can be dialyzed, but they can't be transplanted, which makes little sense in this, because it's much more expensive to dialyze patients than it is to transplant them. But yet that is the situation that exists. And what makes it even more difficult to understand is the fact that when we have this new Trump administration, that they're going to eliminate just about everything that has to do with the Obamacare, which is going to hurt all ethnic populations, but especially populations that are undocumented, and even those that are documented. So I just bring those up to you to have your take on those aspects of how all of this will impact the Latino Hispanic population.
Yeah, no, I completely agree. And I think that to continue with what you were saying, a lot of people say, well, we should not treat them because they're not paying for the healthcare, but they also don't let them pay for their own healthcare, right? So if you let them acquire health insurance, it would make all of us, health insurance cheaper, and it would be better for them. It would be better for the hospitals. But it's one of those things where they decided, maybe they should not get healthcare, and they should just show to the ER where it's more expensive and worse for everybody. And you're just getting emergent treatment, but you're not getting preventive treatment. So you're going to have all these issues where it's a lot more expensive, and you're just going to affect the whole population. Nobody's going to benefit from that. So I think it's something that has been shown over and over. And as you said, the program in Chicago, one thing that I could not get into my talk, but they helped and they worked with leadership to be able to let people get transplanted. And before, I think it was 2012, there was only like 400 transplants done of undocumented people. And since they did it, they've shown that, they pay insurance, that they do well, and that they've done plenty of transplants there. So I think that there are opportunities. And what people have to understand is that this is obviously you're doing it for the good of the patient or the population, but this is not only charity work. This is a business, right? People can make money out of this. So it's a win-win, really.
Thank you.
Yeah, I thank you for addressing that issue, because I did have the same question with regard to the Affordable Care Act and the impending changes to such an act. But I'm wondering, and this ties back into the question regarding culture, the resilience of the Latinx people, the Hispanic people, what have you, I think is very much key. And can you speak to the resilience that comes about as a result of culture and the trust within that culture, so that eventually you will develop advocates that would fight for the right policies, in addition to ensuring that they continue to educate the population, the Latinx population, so that they will find themselves engaging in the work of literally just improving their own health care for the undocumented brothers and sisters. In other words, so those that are legal will help and fight for policy for those that are considered to be undocumented. And then how in that resilience do you see advocates rising up?
Yeah, I think that's a great point. I think that unfortunately, most of the people that come here, they are simple, humble people that they just want to come here, work, provide for their family, and live their lives. So that's why I feel that it's hard sometimes to find somebody that can be this great advocate. But you have seen it, right? It's part of this group of people that they have decided to go through this, harrowing of getting from a place where they're having issues in Mexico. Either there's no work in the best of cases, or they're getting abused in the worst of cases, or run down by other issues, and come here to do very, very hard work that other people don't want to do. And I think that does build resilience, and it shows them what the future can hold if we do things right. I think that they just want, as I said, simple things. They just want to be able to live their lives the best they can, and to have peace and grow their family. And they take those ideals to everybody else, to be able to show that they're just good people doing their best.
It really seems to me that the faith that they have in God, rooted in their Catholic upbringing, as well as the deep faith and trust in each other, allows them to be resilient and to thrive irrespective of the challenge. And I'm very, very interested in that, because that talks about what is understanding place, understanding the significance of family, understanding all of that in order to be a people that will stick together. I will ask you about those that Latin paradox again. I think it's important for our viewers, speaking about the things that they have experienced in terms of being more active and all of that. What is the nature of the activity and the exercise and the being active as it relates to just early stage kidney disease and all of the other diseases? You spoke of less being not quite as obese as others. So Why do you think, as part of your culture, is naturally to be active, and what is the role of activity in recognizing and knowing that that is significant if you're going to curb all of the other diseases like such as kidney disease?
Of course, yeah. I think that a lot of these patients come from rural areas in Mexico or in Central America, where you do not have public transportation, so they're day by day just walking one place to the other, and they try to do the same here. So they're just accustomed to move on their feet, right? To go up and downstairs, to do the regular activity, and you can see that, right? You can see as carrying yourself every day until you're old. You're always walking and always moving, and you can see that how that helps you. We have seen that is one of the ideas of why this Latino paradox happens, right? The people are healthier, they're less obese, and all these things can affect, the metabolic syndrome, have better blood pressure, have less risk of cancer, have, less kidney disease, and be in better shape to be able to take care of, life itself. But I think there are the small things in life, right? It's not, you don't need to pay a membership to go to a gym and work out. Obviously, it's great if you can do that, but it's just making sure that you walk 30 minutes. That I think that knowledge that say that walking is not exercise is not true, right? Obviously, it's better if you can run, but not everyone can do it. If you can just walk 30 minutes a day, take the stairs, all those things impact your lifestyle every day and are going to make you, burn calories and feel better about yourself. And I think that's what happened with this population, of course.
Okay. Dr. Melancon.
Again, Pablo, I thought this was great. And I particularly like the ending because, one of the things I'm immediately thinking about, thinking like a researcher, is the difference between, even at the same socioeconomic level, a lot of times these Hispanic patients are doing better. And they're doing better because of all the stuff you just said. So the activity, a lot of times Americans from all walks of life, but particularly poor Americans, are much more likely to be disabled and be on dialysis and not work. Whereas you see so many of these Hispanic patients that continue to work, that continue to cook at home, that continue to exercise. And you're right, usually they're not a part of a gym, they're just moving around. So I think this is something to learn, in these other populations. And, Dr. Callender is very famous for saying the importance of faith. And that's the other thing, these families together and going to, I passed a Hispanic church the other day. Just packed to the actual, just absolutely standing room only. So I think these things are important as well. So I don't have any other questions, but I just think that it is important for us to see that even at levels of poverty that can be replicated in other communities, that these patients are doing better because of all the little things that you just talked about.
Of course, and I think it shows the importance of all those things, right? Of having, family support, and trying to be healthy in the things that you can do, right? Obviously, we understand that it's a lot more complicated if you have less resources, but there's still ways to do it, and ways that it's not, that it's still going to make you happy, and that it's still going to be enjoyable. And I think that the Latino community has been very good at showing that.
Dr. Callender, anything else?
Yeah, the only thing that I would add to that is the fact that we are now getting ready to go through a situation in which many of the financial resources that are essential for all ethnic groups are being decreased. And this is going to have a tremendous negative effect upon all ethnic groups, especially the Latino group, particularly the undocumented immigrants. And so the importance of what Dr. Curry mentioned in terms of having the advocates from those Latinos who are documented, to help those who are undocumented become something that is important to inspire.
Of course, I completely agree, and I think that there's a lot of people in the community that we're trying to do what best we can to help, our fellow citizens and to help the people here and to do what's best for the patients.
All righty. Well, I think that will do it for us this week. I'm sure we'll get more questions from the audience because, this goes in a loop and we always get more feedback afterwards. But once again, Dr. Serrano, what a great job.
Wow.
And we've seen the evidence right here at GW. And now blackdoctors.org gets to benefit from your expertise. So thanks again. And I'm sure you'll have to come back and join us for a future show.
Absolutely.
Thank you so much. Thank you for the opportunity.
Thank you.
Okay. Bye-bye.
All right. Bye-bye.